Hi, I'm Dr. Amarjan from VERVE Hub, and today I'm going to demonstrate a very interesting, challenging procedure that is REBOA. Yes, resuscitative endovascular balloon occlusion of aorta, and this is one of the recent tool being increasingly used in the management of sick trauma patient. Now, coming to the indication of REBOA placement. This is basically placed when you have a non-compressible torso hemorrhage, or you have a PE because of the accumulating hemorrhagic shock, or you have exclusively pelvic hemorrhage which is not responding to your usual trauma resuscitation and your fast is negative. Then there are certain other non-traumatic indication for placing REBOA, and that is PBH and sometime in GI hemorrhage also. So these are the indication where REBOA is placed, and but its indication are definitely evolving, and in future we will see many more indications where we will be able to use REBOA. And now I'll just show you what it looks like. So this is the REBOA catheter. At the caudal end you can see there are two ports. One is the red one, which is the this is the arc port through which we record the blood pressure, and the second is the balloon port through which we inflate the balloon with the saline. And on the REBOA catheter they are marking 1 centimeter apart, so you know how much advance you have gone inside the aorta and where your balloon will be. And this is the balloon. Come this side. This is the balloon. On either side of the balloon they are radio opaque marking, so you can see when you inflate by shooting an x-ray where your balloon is. So we'll just show you. Yes, this is how it is inflated, and this is the p-tip. This is for recording blood pressure, and this is the protective sheath. So this is the assembly for the REBOA catheter, and now I will demonstrate the procedure. And before that I would definitely would like to talk about the placement zone where we exactly put the REBOA in in aorta. So this is basically placed at three places, like three zones. The zone 1 is from the subclavian artery. You can see inside the subclavian artery and the celiac trunk. That will be our zone 1 placement. The second will be zone 2. That will be between the celiac trunk somewhere here and the renal artery. Now the third will be between the renal artery and the bifurcation of the aorta. And that's where I see a lot of REBOA used in India for preventing PPH death. Now coming to the place where you can do REBOA, you can do in ED also, in OR also, and amazingly and interestingly, London Hams is doing REBOA pre-operatively. So that is very interesting, and now I will demonstrate the procedure itself. So this is our VERVE Hub manikin for demonstrating use of REBOA. So you should be, expert in using ultrasound for puncturing the common femoral artery. There should not be any blind puncture for this procedure. So I have already punctured the common femoral artery, and I have put a 7 French sheath. So we will just remove the assembly. And now through the 7 French sheath we will introduce the REBOA catheter. This is the protective sheath. Now you can see the REBOA catheter advancing inside the aorta. So here is our balloon. I will demonstrate placement at zone 3 level, that is between the renal artery and the bifurcation of the aorta. So we put some saline and inflate it. So you can see the balloon inflating, and just to demonstrate practically, we will push some blood from the aorta above, and you can see that blood is not flowing beyond aorta, below the balloon. So this is how REBOA is done, and I believe that in the future time this will be like available in most of the level 1 trauma center. But I have been told that there is no REBOA facility in India, and that's very unfortunate. And one more thing I forgot, I'm sorry to tell you that nowadays people are using REBOA. Like in this REBOA, you can keep this inside the aorta for 60 to 90 minutes, but in REBOA, that is partial REBOA, you can extend the timing, and that involves like deflating the balloon intermittently. So as I said earlier, it's the technique and the indication are evolving, and we will see more indication for using REBOA. And now, when you remove the REBOA, it is also very challenging time because it can cause hypotension, it can cause severe metabolic acidosis, it can cause increase in the lactate. So you have to inform your anesthetist that it will be quite challenging when you bring down the catheter, when you deflate the catheter, and one should be very careful. Now, I have to tell you one more time, I don't make it more clear that I am here to improve trauma care in India and in low middle income countries, both at basic as well as advanced level through our mannequins and through our company, VERVE Hub. And we have been designing and manufacturing mannequins for various surgical life-saving skill. And this is one of the mannequin and the skill we have designed. And let me share with you that we have through our mannequin, we have been now able to design and commercial launch IO access power driver and needles for human in India. That was not available in India earlier. So our endeavor is to improve trauma care both at basic as well as advanced level through simulation. So now not only mannequins, but we are branching out in simulation as you can also. So today this was the demonstration. Thanks for sparing time, and see you next time. Thank you.